Good afternoon and good night to everybody on this lovely Wednesday night. About halfway to the house already. I was kind of just listening to some music and then kind of got to this one area that I usually record at here because the signal basically just is non-existent on this back road that I take going home. So this is usually when I record, honestly. But I was gonna just mention, yes, I was joking around today with like a nurse extern that I had that I was training. She's getting ready to graduate nursing school and stuff, and she'll sit for her boards, get her RN license, and she'll do great things, I'm sure. She's very bright, has a very kind, caring heart. But just was kind of joking around with her and was like, yeah, these ain't the same patients that Florence Nightingale had back in the 1800s. If she had these patients, she'd probably be a stripper. Admittedly, totally joking when I say that. But in all actuality, I mean, it's not a lie. Like, I've been in the healthcare field in one way or another for, well, basically since like 2012, so 13 years, because I graduated in high school in 2012, joined the Army as a medic. So, I mean, in the healthcare space ever since then. Been an RN since, let's see, what, 2017? Yeah, 2017. So I was a combat medic, EMT, paramedic, and then RN. So, been doing this, roughly 8 years as a nurse. 13 years in healthcare in general. And I gotta say, over time, I feel like, I don't know if it's a little bit of I know more now, so I notice more kind of thing, because admittedly, the knowledge level that I'm at now compared to when I started is, I don't even think saying 10x is enough. I would probably say 50x. So now it's like I know a lot more, so I see a lot more. And also I've been at multiple hospitals and facilities and dealt with probably over 100 doctors and probably another 100 specialists. And so I've been around the block, so to speak, as they say. And like I've seen what works, what doesn't work, both. I did some management. I've started, like I said, like an EMT paramedic. So I started at the grunts level, and I worked my way all the way up to being a manager of a unit at one time. I was like a relief house supervisor at one time, which is where you're basically running the entire hospital. I've done CRD, where you worked pretty much every unit in the hospital. So on the hospital side of things, like, I've been well versed around the block. And it's just, I feel like I notice things that maybe other people just don't even notice, and that's why it's such a thing for me. But also, I just feel like the patients and the families and stuff like that, it's different. It's not what it used to be either, I feel like. And I say that in regards to, not trying to be disrespectful to the patients or saying that I hate my job, but it's like this entitlement. Like, okay, you come to the hospital, you're obviously sick, you got something going on, you fell, broke your hip, got to get surgery, you got a small bowel obstruction, you haven't crapped in 2 weeks, and now you're crippled over in pain, or you're coming to the ER because you're having a heart attack, you're in the ICU because you're in diabetic ketoacidosis, or you can't breathe and we're putting you on a vent, like, that's why you're here. And one thing that COVID did, like, so prior to COVID, it was like it's kind of like a treat them and street them kind of thing, you know, like you treat these patients and everything, you discharge them out, they do their follow-up care. You don't know what happened to them unless, you know, you just happen to bump into them in Walmart one day or something, you know, or if they're what we call frequent flyers, you know, they'll be back next week, guaranteed. And, you know, but there was just that sense of, oh, this is just kind of like how it is, kind of moving on, so to speak. You know, just do your job, go home. You might bump into them someday at Walmart. So that was how it kind of started for me, or how it felt when I started. During COVID times, you know, everybody was, you know, treating nurses and healthcare workers either as like a hero, because they're like, oh, they're out here, you know, fighting this pandemic, they're heroes, you know, this, that, and the other was a big portrayal. The other portrayal was like, admittedly, like during COVID in the beginning, the Walmart and the Harveys where I live at, they had designated times for like healthcare workers and stuff to come get their stuff, like to come shop. Which was, I mean, it didn't last that long. It lasted like maybe a month or two. But they realized, I guess they maybe coordinated with the hospital. I'm not sure exactly how it went down. But they realized, I guess, that the nursing staff changed shift at 7 o'clock. So what they would do is from like 7 o'clock until about 9 o'clock, they would only allow like healthcare workers and stuff like that to come and shop so they could get their things. And then they would just try to, I guess, do a quick little cleanup before they opened it up to the rest of the people that needed to go shopping and stuff like that, or what have you. Which was really nice. But even on like some of my days off, or like if I just got out of work and maybe I didn't make it at that little quote time, you know, and I would go later, and like if I was in scrubs, let's say I was working like a 14-hour shift, I'd get home, because during COVID, so let me preface, during COVID, I was working in the hospital predominantly taking care of vent patients, and either in the ER or ICU. I basically was, for almost 2 years, I felt like that's all I did. And so when we would get to the hospital, we would have to go to the operating room or the locker rooms or the ICU area or the ER wash area, and we would change into surgical scrubs, or these like blue scrubs that the hospital provided. Like, so we would show up in our scrubs, or maybe like gym clothes or whatever, to clock into work and everything. But before we went into the COVID areas, we'd have to switch out into these other scrubs. And then when we would go to clock out, we would switch back into our other scrubs. Well, if you've never worn scrubs, you can buy scrubs that are super comfortable. Like, I buy the Cherokee, I think it might be like Infinities or something like that. I'm not sure. There's not a lot of variety for guys, honestly. It's, when you're a female, you got a million choices. When you're a guy, you got maybe 3. But I got the Cherokee ones. It's the Revolution or Affinity. It's like they're kind of like a loose athletic fit, but they feel like pajama pants, basically. Like, they're lightweight, they're breathable, they feel great. You just pull them up, and then it has, like, if you want to button and zip it, you can do it that way. It also has a drawstring, so you can do it almost like it's sweatpants if you want to do it that way. Just very versatile, fits like pajama pants or sweatpants, whichever way you want to word it. So they're super comfortable, especially during like the fall and winter time when you don't want to wear shorts because it's cold at 6 in the morning. So I would go to the hospital change out into the scrubs they provide, work and everything during the nighttime. Well, then I would get off at 7 in the morning. It's still a little chilly, October, November, maybe December time. And I would get out and I would change into my regular scrub pants and just like a t-shirt. And I think I was wearing like the hospital I was at. I think I might have been at Brunswick or maybe Valdosta, maybe. I'm not sure where I was at. Or maybe I was at Coffee Regional. I was at Coffee Regional actually. So I was wearing like a Coffee Regional shirt and just some scrub pants, and I went to the Walmart to buy some stuff before I went home. And like as soon as I went down this aisle, like I just came around at the front end of the aisle and they saw me in scrubs, and like I'm talking about like 5 people were just cleared the aisle, like they didn't want to have nothing to do with me. So it was kind of unreal during COVID. Like you were hailed as a hero, but at the same time, like no one wanted to be around you because of what you did. So it was a weird time. But as we got out of the pandemic, a lot of that went away. Unfortunately, a lot of new nurses during the pandemic didn't really get trained on anything because of the lockdowns and stuff like that. So, you got some of these new nurses now that, they might have been nursing for about 3 years now, but it's like when they started, it was like the pandemic hit and everything was shut down and they didn't even really get to train because of the pandemic. So you have nurses that were, maybe nurses for 2-3 years, but they didn't know anything but COVID because of what was going on. So then as we're coming out of COVID and we're, getting back into doing surgeries, we're kind of opening everything back up and, getting back to normal business, so to speak, you have these nurses that all they know is COVID because they graduated during COVID. So they don't even know how to talk to families and how to, go in there and break bad news to a patient, explaining and being there like to comfort them and stuff, like when they got a new cancer diagnosis. And that kind of art got lost a little bit. And a lot of the facilities and senior nurses have helped some of the newer nurses get to that level now because we've been out of the pandemic long enough to kind of bridge that gap in a way. But that took some time. So that was one of the things I noticed just being in this game, so to speak, for a while. But the issue that I have with not everybody, but a big majority of patients and family and stuff is the entitlement. Like, you're here because you're sick, you're injured, you got to get this stuff done. You don't have to be a butthole. Like, I don't think people realize, like, when you're working ICU, you're usually at a 1-3, maybe even a 1-4 ratio. And these people are critical care, like they're knocking on death's door and you're trying to keep them alive, and then you get this family member going, hey, Uncle Joe over here, he ain't ate his lunch yet. Meanwhile, you're, 2 doors down with titrating this drip that's keeping this patient alive because their heart's so messed up. And then you're just like, oh yeah, let me not keep this person alive so I can go feed Uncle Joe even though you're sitting in the room with him. And it used to be like the families would kind of realize like, oh, okay, like I can help Uncle Joe. And you still get family members that are willing to do those things because they realize like, oh, the nurses are here to take care of this. They're not our maid, they're not our butler. But I feel like that's getting lost more and more. And and then the administrators and the people that so-called run the hospital, as far as like the big dogs, so to speak, they're sitting there just looking at the surveys and Press Ganey and all these things, and they're like, oh, well, we keep getting patient complaints. And it's like, oh, well, what are they complaining about? Oh, they're complaining because they hit the call light for a thing of water and it took 45 minutes. It's like, oh, well, what was going on during that 45 minutes? Oh, well, we also had a code blue where we were doing CPR on a patient 5 doors down, but, that's not important. Let me stop everything and go get, Grandpa Willie over here, go get his ice water for him because he's going to make our scores drop. And I feel like that's become such a big thing. Like the nurse administrators anymore, they're just looking at scores, they're looking at numbers, they're not really rounding, they're not talking to patients, they're not engaging with people, they're just going to meetings, looking at numbers, and being good idea fairies, as I call them, where they come up with something and they're like, oh yeah, that's a good idea, what do you think? Yeah, that's a good idea. Neither one of us have worked in a unit or even touched a patient in 20 years. But yeah, that's a good idea. And then it gets pushed down to the floors, and the floor nurses who are actively taking care of these patients are like, this is stupid. Like, why are we going to do this? This makes no sense. You're adding more charting on, which takes away from the patient care. Just because of just because of one-off incident, instead of addressing that nurse, you just do like this blanket approach across the whole system to make people chart a certain way or add another thing to the nurses and stuff like that. And then they go, oh, well, you weren't able to get those dressing changes done? Well, not when I have to chart for 10 hours of my 12-hour shift. And then you'll go to some facilities that are doing it right. And when you get in those facilities, they wonder, why some of these hospitals don't have staffing issues like a lot of the others, or, their retention is so high. It's like, okay, well, what are they doing? For instance, like Emory has a really good retention. What do? Oh, they actually help their staff. Like if they're RN and want to go back for their BSN or their MSN, or like they have stuff in place to help them get that next degree. Or maybe they're a phlebotomist who wants to be an RN. There's these things that are put in place. They also have like pay increases and stuff like that based on retention. You have all these things put in place, and they give you kind of a clear trajectory of like, hey, if you do XYZ, you get to this level. And it was kind of the same way in the Army, as like you kind of knew what you had to do to get to that next level. And then they kind of gave you the tools, so to speak, to help get you there. You still had to put forth the work, but at least you had the tools to get there. Well, then you go to other facilities, and for instance, I'm not going to name any names, but you've been nursing there for 3 years, and all of a sudden this new nurse that just graduated is making 50 cents less than you, and they got a sign-on bonus. And then when you put in your notice and everything, they're like, oh, well, what's going on? It's like, well, you say that the raises and bonuses and things of this nature are based on performance. In this past year, I have gotten a bachelor's degree. I went from being a regular floor nurse to a charge nurse to then later becoming a nurse manager. I took on more roles. I joined the shared governance counseling also, because that was the next thing you suggested I do to climb the ladder, to get that experience. But yet when it comes time for raises, I'm getting the same 20-cent raise as the LPN that just graduated And then I'm also only making $1 more than the RN that just graduated, even though I've been an RN now for almost 4 years or 3 years with a bachelor's degree, and I'm on all these councils and everything else, but I'm only making $1 more. And then they're like, oh, well, what do you think? Da 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 da. It's like, well, if you're giving like 20-cent raises to everybody like that, then I think I should at least get $2 raise. Like, I should have got something for the BSN. I should have gotten something for being a charge nurse this year. And then I feel like I should have got something again for taking on managerial roles. And you didn't have nobody to be a manager, and I stepped up and filled that role as an interim. And then later, I was doing so good as the interim and turned the unit profitable that was actually losing money. And I got the staffing matrix fixed, and you're still not giving me nothing. Like, that's a problem. And they're like, oh, well, the budget, this, that, and the other, we can't do it, da 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 da. So you go home, think about it, and all right, here's my notice. I'm leaving. And then they wonder why they can't keep staff. I mean, the answer is clearly right there in front of you of like how you're treating your staff. Or a different facility I've been at, the VP, like the vice president and the CEO, walked the floor one day, and then this was like kind of trailing out of COVID. They're walking the floor, VP, CEO walking the floor, giving out pizza, because that's what managers do when they're about to screw you over, basically, is do like a little pizza, or they already screwed you over and they try to make it up with a pizza party. Nobody wants, because they get like Little Caesars. They don't even get decent pizza. But anyways, so they do that, and then the VP and CEOs walking the floor like, oh, thank you, we brought these pizzas, da 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 da. And I, as like a charge nurse, I've seen you in meetings, so I know who you are. Just because I've seen you in some of the charge nurse meetings sitting there looking at me stupid for saying like what's on my mind about how your good idea isn't feasible on the floor because of these other issues that are already approaching. Or I'm asking, why are we not fixing this? Why are we looking at this instead of this when this is a bigger problem? But you're sitting there going around on the floor and nobody knows who you are. Like, your own staff that you're over has no idea who you are. Staff that they're not even new. Like, some of this staff have been there a year, 2 years, and has no idea who you are. Because you're not approachable. You're not out there talking to the people that you're over, and then they wonder why, oh, well, I don't understand why they don't want to work for me. It's like, we don't even know who you are. Like, you're just this name that sits in an office and comes up with bullcrap ideas that make our life miserable. And then you wonder why we don't want to work for you. It's like, how about you come out here to the floor, you help on the floors, see what's actually going on. And then instead of like just coming up with good ideas, why don't you talk to the people that's actively doing it and be like, hey, what have you noticed? Or talk to your charge nurses that's leading your units, that's there every day on those units, and be like, hey, what's something that you notice that we can do? Like something small that'll make it easier for y'all and help y'all get through these days. Or, hey, like, we're experiencing a lot of issues with post-operative infections with these surgeries. Like, what's something you notice that might help? Like, do we need to do certain things, or is there something else that we need to take off of y'all so that you can fix these infection rates? Because these readmissions are killing us, you know. But no, nobody's doing those things except for at a few facilities. And then the few facilities that are doing these things, they're doing great work, and they're the hospitals that are expanding. Like, it's just kind of common sense of, you know, is this person a boss or a leader is what it really boils down to. And then those people in the A bucket where they're not doing those things, they're just a boss. And then if they're in the B bucket where they're going around, they're talking to people, like, those are leaders. Like, for instance, I'm charging the unit and I see one of my nurses is sitting there holding, like, kind of like her pelvis area. I'm like, hey, what's going on? She's like, oh, I think, I got an ovarian cyst. I'm just having kind of a flare up. I'm like, okay, well, what do you got to do? Oh, I got to finish these last couple vitals, this, that, and the other. They're like, hey, have you taken anything for it that's worked in the past? Oh, well, usually I can take a little Midol and maybe put like a little heating pad on it, and it kind of goes away. All right, I'll tell you what. You go to your car, go get your Midol, go get make you like a little heating pad with the towel, like kind of warm it up, and I'll finish out the vitals real quick. Just go get that done, and then take like a little 10-minute break here, get all that done, and see how we're doing, okay? All right. I guess the charge nurse stepped out of that charge nurse position, and I'm doing the tech work now. So I'm going into the rooms, I'm getting the vitals, I'm getting the blood sugars, I'm changing the diapers and stuff like that, and doing all these things. Now, I come back to that tech later. I'm like, hey, how are you feeling? Oh, I feel a little bit better. I'm just trying to get through the rest of this shift. Da-da-da-da. I'm like, okay, let me know if there's anything else I can help you with. Yeah, no problem. Now, guess what? When it comes time for me needing a tech one day, like, for instance, a couple weeks later, I'm short a tech, and I call that tech up because I'm just trying to get anybody, because I'm short, because someone had a flat tire, wasn't able to come to work, whatever. So I'm just calling people. I'm like, hey, you don't have to. I know it's your day off. We're just short a tech. If you're able to come in, I'd greatly appreciate it. Now, you got that person asking you to come in versus you got the person that sits in the office all day, assigns rooms, looks at and then asks you like, hey, is that room stripped? Hey, have you taken those blood sugars yet? Hey, why are we da-da-da-da-da? Which one, when they call you up and you're like, hey, we're short staff today, you don't have to come in, but if you can, that'd be great. Who are you going to come in for? I mean, the answer is plain and simple, and how people can't wrap their mind around that just baffles me to an umpteen millionth degree. But anyways, I'm going to finish up this drive. I'm almost to the house now, just ranting and raving at this point. But y'all have a blessed day. Give the kids a hug, kiss, smack the old lady on the butt, let her know you love her. All those good things. And I'll see y'all beautiful people next time.